Test 1, 2, 3. know what? God takes care of me. I've said this my whole life, and it's true. So let me turn my phone off because I don't need it going off. Right? You don't want that going off, right? So let's do this.
All right, it's 9 o'clock. Whenever you get ready to go, we can start.
So welcome to St. Vincent's Health System Fractured Families Domestic Violence 101. I'm Pat Speck. I'm a professor at the University of Alabama at Birmingham in the School of Nursing. And so let's start out by defining the different kinds of trauma. They're experiences that produce enduring emotional pain and distress. Think about what that means. And then I have some slides where I have to disclose under ACCME guidelines, I do have financial interests through my husband and son who are owners of My Eco Health. I haven't received no financial support for the presentations. However, I will receive an honorarium from the Medical Education Speakers Network for this presentation. I will not discuss off-label use or investigational use of products in my presentation. But that's not all. I'm also a funded researcher. National Institutes of Justice, Office of Justice Programs, Department of Justice, CMMS, Health and Human Services, Office of Violence Against Women, and Office of Victims of Crime. And I have an additional disclaimer. While I strive to make the information as timely and accurate as possible, I make no claims or promises or guarantees about the accurateness or completeness or adequacy of the contents for this presentation. There's no warranty of any kind expressed or statutory. While not including references in this presentation for a specific commercial product, it's not intended, and I've tried to eliminate all of it. However, if it happens to come up, it is for information and convenience only. It does not endorse, recommend, or favor that producer. And the photographs today are from Creative Commons whenever possible, and are government sites and are for educational purposes only. There is no intent to harm the copyright owners. Your professional responsibility, while I bring the published evidence to you, evidence emerges daily. It's the responsibility of licensed professionals to seek out and understand, interpret, and implement best evidence in your practice, as well as peer-reviewed competency and competence. The author presenter assumes no responsibility for your interpretation of the material, and it's presented as it applies to your practice. So these are our objectives today. We're going to review the epidemiology and current science of evidence for the healthcare intervention in domestic violence. I hope to help you recognize the cycle of violence and assess where the patient's domestic violence in the relationship fits into the cycle, and recognize there are health outcomes from domestic violence. There are also lethal offender strategies that you need to recognize as a healthcare provider, and then there are victim presentations. So I want you to review the domestic violence legislation and definitions and coordinated community response. I'm using Alabama today because that's where I'm located. However, you can locate these items in your state regardless of where you are. So we're going to utilize resources in the local community like domestic violence centers, and I'm also going to share with you how to find them. And then there is a legal system process and a witness role if you're involved in the care of a person who has been victimized in a domestic violence relationship. So what is it? In the United States, about 20 people per minute experience intimate partner violence. That's more than 10 million abuse victims annually, 1 in 4 women, 1 in 9 men. And when we look at what is commonly considered domestic violence, this number is probably underreported. When you look at injuries, and that's really important for healthcare institutions, because only about 10% of the victims will seek care. And when they do seek care, they may have alternate explanations for their injury, and it's up to you to have a suspicious eye. When we also have 1 in 7 women injured and 1 in 25 men injured. So when you look at that, think about even with the men, and this is particularly important. While it is typically women injured, men are also injured. Now, when it says 34% receive medical care, that is not necessarily for their injuries. It is, in fact, they'll present to the hospital and they'll have things like anxiety. And that anxiety expresses itself in lots of diseases, depression, suicide, ideation. Let's talk a little bit about women who are murdered by their partners. And these folks actually have early symptoms and warning that I hope to teach you about today. So each year, 7 million women, 5.6 million experience some level of violence. Intimate partner violence is about 15 to 4% of men and 15% of women. The emergency department is often the first place where there's opportunity for treatment. And between 5 and 38%, depending on the study, will seek emergency treatment. Now, when we look at that, you have to think about what is the opportunity for intervention to stop the cycle of violence. Well, there are some conservative estimates from an epidemiologic perspective about the statistics that with domestic violence, you also have 2 million abused and neglected children. So those of you with pediatric interests and practices need to begin to look at the family constellation that is chaotic. When 2 to 4 million are battered women and 8 to 12 million women are at risk at any given time, and when you look at the 35 to 50%, depending on your location, are related to intimate partner violence homicides, where 8 to 10% are women killing the men, then we have significant issues associated with those stats. Again, I said depending on who you read, 5 to 25% of the ED visits by women, only 7 to 10% are screened routinely, even though JACO requires it. And about 50% of them overlap with child abuse, an even larger percentage overlap with animal abuse. So what about during pregnancy? These are opportunities for you to realize that this is part of the abuse during pregnancy. 8 to 22% of women who are preeclamptic or hypertensive experience domestic violence, as compared to those who do not experience domestic violence, 7%. The most significant risk factor is a pregnancy for domestic violence, and the reason for that is the woman now is turning inward, and the partner is absolutely, whether it's male or female, in gender-to-gender based violence, it is about not being able to pay attention to that power and control. When we look at ethnic groups, they're lower than in Hispanic couples, so that African American and Anglos have more domestic violence. So we know that a lot of researchers, Ebby, Gideon, Campbell and Alford, Berenson, they all identified 40 to 45% of physically abused women are at increased risk of STIs, HIV, pelvic pain, PID, and infertility. They're at risk of being a homicide or suicide victim. They have very low self-esteem. Many times it's an unintended pregnancy, unplanned. Adolescent pregnancies almost always have to be assessed because adolescents who are pregnant have a high percentage of first sexual encounters being rape. Anal vaginal tearing that occurs doesn't heal, painful intercourse from the scarring that occurs. So when we look at the strangulation, which is a component of domestic violence, I'm going to tell you that 1.5 million women are strangled in the United States every year, and manual strangulation with hands makes up 80% of that. Of the 80% of manual strangulation cases, ligature usage is involved in only 15% of those cases. 85% of strangulation are women, and most strangulation events occur at home, and only 10% seek medical care. However, I want you to pause here because strokes in women less than 45 years old are associated with a history of strangulation. So related to that is an injury to the carotid or the venous systems that is undetected because you don't look for it. We'll talk about that in a minute. So here's the signs of strangulation noted in this poster that's available from the Family Justice Legal Centers. It's also available on the Strangulation Institution. And I want to bring your attention to the injuries in the neck are mostly not there. In women of color, it's difficult to see the rubra from a strangulation. So it really has to come from a history. And unlikely the patient is going to use the term strangulation. More likely they're going to use that he choked me until I passed out, or I couldn't breathe, or some other complaint that's going to alert you that this is a strangulation. And so why am I spending so much time on this particular injury? One, we have opportunity for intervention if there's a carotid tear or a venous tear. Two, it reminds me of the seat belts before we started doing contrast CATs. We had no idea that the seat belt would be responsible for one of the circulatory system's major injuries in the neck. The other signs you're going to look for in the mouth, certainly tongues, bruising and swelling, petechia around the eyes and eyelids, particularly when you see red conjunctiva. Don't think hemorrhagic conjunctivitis. Think about strangulation. Behavioral changes are there. There's an amnesia. They can't give you a good history. The face is reddened or flushed, and it's reddened or flushed above the strangulation line. When there's voice changes, the raspy voice, painful to swallow, some nausea, drooling. In the chest, if they sit on the chest and obstruct the venous return, then you're going to see some of these same things. On the neck, it's likely the fingernails will scratch the neck in downward motions, and that's in an effort to be able to breathe. And of course, there may be a hyperventilation. I want you to look at the picture on the right. This is a domestic violence strangulation case, and the presentation is a picture on the top. Within about 4 to 5 days, the swelling in the face returned, and in 2 weeks, when she appeared in court, she's the bottom picture. You can't know with a one-time encounter what she looks like. You must ask. The contrast CT of the carotids documents a hypoxic traumatic brain injury. How are you going to address that? Well, here's one way. There are sample strangulation discharge sheets available, and I've given you the National Domestic Violence Hotline here and the URL. The Strangulation Institute provides a number of toolkits for your institutional policies and procedures when it is detected. So after you do a thorough evaluation, make sure that they understand the seriousness of what has happened. Again, it's much like seat belts. Before we became aware that they can injure neck circulatory system structures, this form lets them know how serious the injury is. As the provider, you need to know and tell them if they have certain symptoms related to stroke, hypoxia, brain injury, to return to the emergency room, because stroke is a risk. All right, so billing. The T codes for injury are easy to remember but are rarely documented. Remember that S codes describe the injuries to a single body part, and T codes describe the injuries to an unspecified body part. If the physician can't determine the intent of the injury, then it's always accidental. But that may change after you document as the history unfolds with law enforcement. And so here's an example of asphyxia with pressure, strangulation, and constriction. And that is from the ICD-9 Volume 2 Index. And those of us who use ICD-9 and 10 know that there's overlap, and there's a lot of tools online to help us figure out which is the appropriate code to use. Then there's also the T codes that I've listed here is a mechanical threat. Due to assault, that is the intent, and it would be an initial encounter. And if you are undetermined, the one on the right. So here's a couple of more. This is a T code, asphyxiation due to lack of oxygen. And then from that, you can go into traumatic brain injury, hypoxic injury. That's also when there is a mechanical threat. So these are approximate conversions between 9 and 10, but you may find them useful as you make plans in your different programs. So let's talk about Lenore Walker. Lenore Walker in the 70s described the cycle of violence to explain why a person's behavior or a person who commits domestic violence and family violence may actually change over time. So it starts off innocent and begins a tension building, and then the cycle goes to the next phase, which is the violent episode, and then there is remorse and the honeymoon. I'll never forget a patient that I had who was in the hospital for a liver laceration. She had been strangled also and was somewhat disoriented. But 2 days later, when I came in as a consultant and saw her, her room was full of flowers. She had a brand new golden ring on her finger, and her story had changed. This is a great example of honeymooning and trying to get her to not tell the entire story. I have another one for you to look at. This is the Duluth model that was developed in the 70s. There's little changed except under the use of male privilege. While we actually believe that males are the primary perpetrators of domestic violence, we recognize now that women are a growing number of domestic violence perpetrators. So look at male privilege as privilege. And privilege, particularly in gender for LGBTQI persons, these gender privilege come with an assignment of a role. And if one role is over the other, that's what we call privilege. Same characteristics can apply to both genders. One phase, tension building. What does the women feel like? Well, they're angry, unfairly treated, hopeless, tense, afraid, embarrassed, humiliated, disgusted, depressed. Difficult to tell anybody about it. And what happens in an effort to minimize the violence, they become nurturing and submissive. They say it's like walking on eggshells. They're afraid to express their feelings. They may use alcohol and drugs to avoid a situation. What's that partner doing during phase 1 tension building? Well, they're tense and frustrated, disgusted, self-righteous, jealous. And at this point, they're verbally and emotionally abusive. They have fits of anger. They may slug a wall. They're either real silent, they're very controlling, somewhat arrogant, possessive, demanding, irritable. They also may use drugs and alcohol. So phase 2, the woman feels frightened because she's trapped, helpless, and numb. Her behavior is she's going to protect herself. So as a healthcare provider, I look for defensive injuries. Injuries to the forearms, injuries to the back of the head and the neck or the back. I look for places where she can't curl up and protect the area, bruises on the buttocks, bruises on the inside of the legs, bruises on the feet. They submit helplessly to the injuries, and if that's particularly true if they can't get away or seek help. What's the partner feeling? Angry, jealous, frustrated, dangerously violent during this, has a deliberate desire to hurt or kill. They're out of control, they're irrational. This is what victims tell us is the Dr. Jekyll, Mr. Hyde. So phase 3, after the outburst and the injury, remorseful and honeymooning. Relieved, the woman feels angry over the incident, resentful, guilty, offers excuses for the batterer. She may be withdrawn, tries to solve or prevent future incidences. She hopes or believes that changes that they make during the honeymoon will last. How does the partner feel? Apologetic, remorseful, wants to forget about the degree of violence, very self-righteous, unable to understand why the woman's still angry, makes promises to change and blames her or others for the problem. During this time, they actually may use a lot of alcohol to forget. So, what is domestic violence? It's a willful intimidation and physical assault, battery, sexual assault, other abusive behavior. The frequency and severity of domestic violence varies dramatically, and the prevalence in each community is available online. It doesn't matter what the age, socioeconomic status, sexual orientation, gender, race, religion, or nationality is. The physical violence is often accompanied by emotionally abusive and controlling behavior as part of a much larger system pattern of dominance and control. Can result in physical injury, psychological trauma, even death. In my patient population, it'll be the diabetic who comes in who's not changed her diet, but the sugars are up. They're under so much stress. This stress, we now know, epigenetically crosses generations and is inheritable. So in Alabama, assault is the threat of bodily harm. Battery is actual harm. Battery is where the word batterer came from. Emotional abuse in Alabama is not illegal, but it causes harm nonetheless. Assault and battery are both a crime. A person can be arrested, and more recently, victims are suing their batterers in civil court for harm, particularly mental health harm, where they need treatment. So I have a Why Doesn't She Leave? There's a YouTube URL at the bottom of this slide on the left side. Feel free to listen to that as a woman and her husband talk about their experiences. The first 2 minutes, 45 seconds are telling, but the actual film is 11 minutes long. So, historically, healthcare providers want to treat physical injury only. It's, they say, it's opening Pandora's box. It's opening a can of worms. I don't have time for that. It's a fear even of offending the patient. It's too close to comfort. Maybe they have an experience in their own family. They say things like, what happens in Vegas stays in Vegas. And then the other thing, you blame the victim. She can leave if she wants to. Well, really? Or she always goes back. So what type of provider are you? I decide for you all your medical treatment. That's a paternalistic model. I give you the facts. That's the information model. I tell you what my preferences are. That's a deliberative model. Or you can be an interpretive model practice where you give the person the facts and then you help them find what your preferences are, their preferences. So you guide them through the process of making good decisions for themselves. Remember, patients don't decline, they don't become non-compliant. They actually decline your services based on their circumstances that you can't know about. So there's specific recommendations, and ACEP in 2014 says emergency personnel assess every patient for intimate partner violence. Emergency physicians, nurse practitioners, physician's assistants, pretty much everybody in the triage line needs to be asking. And patients get impatient with that. They say, of course not. They deny, because to admit means that it's going to open up for them something they might not choose to address at this point. There are best practices, however, ACEP supports. Let's look at another one. They are opposed to mandatory reporting, and there's reasons for that. Instead, they encourage partnering with community organizations to find out the local services in the criminal justice system. And in collaboration with the community, they can develop, healthcare systems can develop policies and procedures. Emergency departments are encouraged to bring in the community partners, particularly advocacy centers like the YWCA or family safety centers. Remember, you're there to treat the medical needs of the patient. The domestic violence arena is much too large for medicine to cure. It requires a comprehensive community response, and in this case, an organizational multidisciplinary training that we're doing today. So if you're going to screen, universal screening is patient-centered and trauma-informed. I'm going to tell you that it applies to the health worker first. Do the reflection and find out, are you being targeted in a domestic situation where you are the victim or the perpetrator? Are you the batterer? Are you the emotionally abusive? If you don't take care of yourself first, you cannot take care of others. So, during routine history taking, all patients are discreetly screened. That means you've got to provide a safe place for them. Confidentiality is expected and, in fact, protected under HIPAA. Document objectively. Don't put words down that are opinions. And never, ever screen in front of the batterer. This is why, and you've probably all seen them, they come in with the partner and they want to be present and hover entirely through the visit. They want to control what's happening. In this case, for the victim, they sabotage and hurt and humiliate. They destroy things of importance. They have sex, reproductive activities, finances, and jobs, my way or the highway. They are blaming you for all the outbursts. In your case, you can provide a trauma-informed encounter, having a safe environment screen, interviewing the patient directly but non-threatening in a confidential manner. Some things that I say, are you in a relationship with someone who threatens to hurt you in any way? Or, I noted a number of bruises on you. Could you tell me how this happened? If you remain patient-centered, the patient will get the idea that you really do care. HIPAA always applies. This is a URL to take you directly to what happens if there's an active law enforcement investigation. Your risk management attorneys should be aware of this, and they will create policies unique for your state and your institution. So another trauma-informed encounter, you're not alone, you're not to blame, there's help available, even saying, I'm sorry this happened to you. So when the patient declines, not is non-compliant, but when they decline to validate because you've done such a great job, document what the patient says. If you have photography, use it, and use it in a forensic manner where you have bookends, 90-degree angles, and rules of thirds. If the patient continues to deny, chart physical findings of injury are inconsistent with the history. Implement the multidisciplinary, multi-organizational response. Do not sanitize your documentation, but be very objective. So why is this important? Well, we've all heard about the ACEs, or Adverse Childhood Experiences, and what that means is there are neurocognitive changes that will occur in children, and it's likely your adult patient has an ACE score. How do you determine that? Well, it's likely associated with the chronic diseases they bring in. We know that historical generational injury is passed down. We know people who survive wars die earlier than people who are not in war situations. It could be societal, discrimination, or race, gender, things like that. You have adverse experiences, and then it changes your neurologic development, how you think, how you articulate with the world, and then risk behaviors are adopted, primarily to calm the vagal nerve. So things like smoking that cause your diaphragm to go down when they inhale actually is a vagal nerve stimulus for relaxation. So the smoking is a problem. Obviously it's addictive, but the mechanics are also a part. Risky behavior occurs. They adopt things that might hurt them, and then you start to see disease and disability. All of that leads to their early death, according to the ACE studies that are on the CDC site. So, adverse experiences, this is directly from the Wave 1, Wave 2 data. It includes all of the different challenges, and you can see that the abuse challenges, particularly physical and sexual, cause significant damage to the psyche. Household challenges, not so much, but separation, divorce. And then there are some new studies that actually are adding things like frequent relocations. And so I want you to think about the military families and how they frequently relocate, have war experiences, have separation. And we may see higher rates of domestic violence in these couples. So this is from the CDC. Also, the adverse experiences have lasting impact. Things like traumatic brain injury, depression, unplanned pregnancy, HIV, cancer, diabetes, heart disease, alcohol, drug abuse, and it ultimately impacts their capacity to move through college and things like that. Dr. David McCollum in 2014 looked at the literature, and this is called COLEVA, which is Consequences of a Lifetime of Experiences of Abuse. This schema is found on the Academy on Violence and Abuse website that is noted on the slide. Important, it involves all body systems and all stress diseases. So, ACEs can be prevented. And how do we prevent them? Well, the CDC has come up with a number of categories by strengthening economic supports for families, changing the social norms, and positive parenting that needs to occur in families. I think about the nurse-family partnership at the University of Alabama at Birmingham School of Nursing that has already demonstrated an increase in full-term births in these high-risk moms. Provide quality care and education early, enhance parenting skills, intervene to lessen harms, and prevent future risk. Have those frank conversations, bring in the community support systems so that people know that there's options for them. So Birmingham's Family Justice Center is one of many across the nation, and they have lots of partners. Likely it exists in your community too, if it doesn't consider developing one. The partners are the YWCA, that's been involved in domestic violence since the 1900s, early 1900s. Crisis Center in Birmingham is a suicide prevention line, but also has a rape program. And then, of course, law enforcement is also involved. So the mission of the One Place and all Family Justice Center is coordinated services to victims and survivors of domestic violence and sexual assault, multidisciplinary teams working together under one roof. So who are the community supporters? Of course, this is a community supported event, and these organizations are likely in your community too. Community foundations, junior leagues, Verizon, United Way, and then certain companies that take a special interest, maybe because of their family experiences. So let's talk about how to look up the codes for domestic violence. And I'm not a lawyer, so that's my disclaimer, but even I can go and look to see what the reporting requirements are in the state of Alabama. All of these codes are listed on the internet, so you can go to your state and look it up. And I know the writing's too little, but let me read some. And it's Article 7 and 7A. It's about domestic violence and other related offenses. And then if you dig down into that article, then you're going to find chapters. And one particular, Chapter 6, offenses involving danger to a person. And then if we look at Chapter 6 and we go to all the codes associated with that, that's the list on the right. And I won't go through all of those, but let's just look at one of them. One of them is first-degree assault or stalking with a child present. What do you need to document in your record whether or not children are present during these events? Because it actually increases penalties and more likely will capture the individual and get them the treatment that they need. With the defendant, you have to look at what kind of separation there will be, because once jailed, that becomes an ace point. Minimum term for these offenses, warning ahead of time may actually modify behavior. 1 year first offense. It doubles to 2 years if a child is present. So think about what it means. There is a site about victims' rights that's listed on here that you can go and look at your state. And you can see who the mandatory reporters are, and what I did is I listed the Alabama code because that's where I am, but you can find this code in your state. There are exceptions for providers. A program may need to consult several laws related to mandatory reporting. If you're working on the team as an integral member from your institution, then they will actually help you with that. There's another element here, danger to self or others. In Alabama, everyone is a required reporter for this. Let's see how it works in Birmingham. And I know this is a huge slide, but I'm going to start with the people because I don't have a pen here. I want you to think about, look at the call 911, and then follow that purple around. This slide represents what happens pretty much in every community. There are a number of professionals that will respond to domestic violence. In this case, we have the squad investigators investigate. They either arrest or they don't. If they arrest, then they go to jail. They're arraigned in a hearing, and then they end up being released until trial. So let's go down and let's follow this arrest report. If you go to the blue, the first thing that's going to happen is that this team is going to determine if there's been any child abuse with this, and there will be a protective child investigation. And that will occur through the state agency mandated for investigations of child maltreatment. So once this assessment occurs, then law enforcement is notified. They include that in their record, and at that point, their record will go to prosecution. So let's look and see what happens when the investigator notifies the location where they live, because now they're in jail and he's being evicted because she got a no contact order, and that is the family court hearing in purple on the bottom. All right, so let's look at what's happening with the child in advocacy programs. Could be the mom's going to seek shelter, and the judge reviews all these situations and determines if and you're following this kind of orangey line down, if relief is going to be granted, and the judge will do that. So in the meantime, the child welfare assessment, you have a separate activity going on at the court level in the blue on the top. There's child placement, there's investigation in what in Alabama is called CHIPS court, and they go through an assessment, psych, mental health, parenting, education, visitation, etc. They actually end up with a case manager, service plan, safety plan, risk management, emergency placement if necessary. And if necessary, these organizations in the community become the safety net for the individual. In every community, this is what happens. It may be named differently, but you have the actual structure that is much more complex than the healthcare delivery. So, okay, you may be called as a witness. Not to worry, you are a fact witness to injury and treatment. And I recommend that you stay in your lane. The MD or RN is likely going to be called to explain the wounds, the history. Be sure and get a detailed history. What is said to you in a history is actually an exception to hearsay, and in court you're going to be able to say what was said. There are a couple of reasons for that. One is the courts believe that patients don't lie to their healthcare providers, and for the most part that's true, but they will create alternative explanations unless you are savvy at addressing the inconsistencies. When you go to court, you'll have the record. It's unlikely you're going to remember it individually, and unless it was particularly heinous or had a significant outcome. In many cases, states will have laws that protect physicians. They can do depositions, they can testify electronically. The key is stay in your lane. What did you see? What did you hear? What was your thinking? Did you rule out other reasons? And then don't overstate your opinion. And don't give the court what their job is. So if you document domestic violence, that's for the court to decide. What your documentation would be an ICD-9 code, ICD-10 code, or some combination thereof. The only way that you're going to be challenged is if you get out of your lane and you start talking about things that you don't know anything about. Remember that when you are seeing a patient, they may or may not give you an accurate history. Document what you see. Ask the questions about child involvement or vulnerable adult involvement. So let's say they have an adult living with them that has a vulnerability that creates them, maybe they have a guardian appointed by court or something. Either of those would constitute a important piece of information in the medical record. One, you need to know that because if there are other people in the home and you're going to hospitalize, you want to call in social work or any of the other disciplines in your organization. So, with the last few minutes that I have, I want to say to you, thank you for all that you do for the patients that you serve. There are some very clear guidelines available to you today, whether it's through SAMHSA's Tip 57 on trauma-informed care, the Strangulations Institute with a toolbox of things to use, or with community activities in a coordinated community response. So again, thank you very much. I hope you have a blessed weekend. In fact, I'm ready. Can you see human trafficking, modern slavery?
Can.
Okay, let me get this up. And how many minutes are we into it? It's 57, so I get, let's
Whenever you're ready
do
to go.
stopwatch, and that will
Yeah, whenever you
be,
get ready to go, just start.
all righty. I'm gonna, hold on, 57, I'm gonna do, no, not a stopwatch. What do I want here? I want a timer. And so now I'm gonna do 60 minutes, no, 55 minutes. How about that?
Okay.
Welcome to Human Trafficking, Modern Slavery. I'm Pat Speck. I'm a professor at the University of Alabama at Birmingham School of Nursing. I have a slide here under ACCME guidelines. I have a financial affiliation with MyEco Health. My husband and son are owners. I have received no financial support for the presentations. However, I will receive an honorarium from the Medical Education Speakers Network for this presentation. I will not discuss off-label use or investigational use of products in my presentation. I'm also a funded researcher, National Institutes of Justice, Department of Justice, Center for Medicaid and Medicare, Health and Human Services, Health Resources Services Administration, Office of Violence Against Women, and Office of Victims of Crime, and others. I have an additional disclaimer here. I strive to make the information today timely and accurate. I can make no claims, promises, or guarantees about accuracy, completeness, or adequacy of the contents, and I expressly disclaim liability for errors and omissions. No warranty of any kind is implied, expressed, or statutory, and the warranties of non-infringement and third-party rights, titles, etc., except for even a computer virus, given the respective contents of this virtual presentation or its links to other internet resources, and I have several in here. While not included, reference in this presentation to any specific commercial product, process, or service, or use of any trade, firm, or corporation name is for informational purposes only and for the convenience of the public watching, does not constitute an endorsement, recommendation, or favoring by this author, me. Photographs from Creative Commons or government websites are used for educational purposes and are without intent of harm to the copyright holders. So, while me, the author, brings the published evidence to the topic discussion, evidence emerges daily. It's the responsibility of you, the licensed professional, to seek out, understand, and interpret and implement best evidence for their practices, as well as peer review processes for competence and competency. I assume no responsibility for your interpretation of the materials in this presentation. We do have some objectives. We're going to review the epidemiology, identify risk factors for succumbing to human trafficking, or the life, as they tell me. Reviewing current legislation and influencing interventions in the U.S. We're also going to look at the interprofessional healthcare team, understand the current research, recognition, assessment, and interventions, and the validated methods identified for supporting persons who are coming forward. We use a trauma-informed and patient-centered environment to do that. I'm going to identify mandatory reporting, local resources for victims in the Birmingham area and surrounding communities. However, these resources are likely available in your community also. So I want to introduce you to a multidisciplinary group of professionals dedicated to ending human trafficking. That's HEALS Vision. It's run by physicians, nurse practitioners, physician's assistants, social workers, etc. These are the stakeholders who are bringing forth evidence that I'm going to try and present today, and I'll mention them several times. As a provider, you can go in and apply to any of these boards that they are promoting prevention of trafficking. There is legislation In order to understand the care of persons trafficked, the essential content will include legislation, not just in the U.S., because it didn't begin there. It began in the United Nations back in the 70s and 80s when they looked at the violence against women. There is a State Department TIP office, the President's Interagency Task Force that monitors human trafficking of persons and assists in the prosecution that will prevent, suppress, punish persons that are trafficking in persons. And it will protect the women and children. And the Palermo Protocol actually supports all of the United Nations conventions against transnational organized crime. So the Palermo Protocol, what is that? In 2000, the protocol was written at the UN Convention, and it supplemented the convention actions against transnational organized crime. Over the years, it's been the source of much clarification, particularly involving the issue of transnationality. It was the first international instrument to define the word trafficking in persons and provides insight into the ways traffickers commit this crime. The Palermo Protocol uses trafficking in persons as an umbrella term. And there's probably 35 or 40 different types of trafficking, but this was the foundation necessary in order to build policies that criminalize human trafficking and stop traffickers, protect victims, protect against victimization, and promote cooperation among countries. While I'd like to think this 50-minute presentation provides all of you information to address human trafficking, in my experience, it takes months to create an environment where providers are trauma-informed and ready to address the needs of patients experiencing human trafficking. So in 2018, HEAL Trafficking Education Training Committee published the essential content for education of healthcare professionals, and there's a toolkit that is associated with that, and I've got that URL for you there. So what do I hope to do today? The HEAL Trafficking and Training Committee developed this particular figure, and I think we're going to be able to get through the education, increased recognition, and interventions. If your community has it, we will also look at those referral processes. So once recognized, is how do you ask? My experience is that people will not tell you they are trafficked. They will give you all kinds of explanations for their situation. It takes a skilled eye to recognize the unusual presentation. Then the question that one would ask once you recognize it is, how do I intervene? How do I report them? To whom can I report them? I'm going to introduce you today to a very basic primer about human trafficking. I'll leave you more to read, but the resources, if there are teams that begin to tackle this pervasive problem, we're going to take a look at that right now. So, definitions, who created them? United States considers trafficking in person, human trafficking, modern slavery to be all interchangeable. And in the Trafficking Victims Protection Act, and I'm going to call it TVPA from here on, it's been amended to address the science as it emerges. And it's a compelling service using a number of different terms, including involuntary servitude, slavery practices similar to slavery, debt bondage, and forced labor. So following the Kilpatrick pyramid, who is the researcher on this, our objective today is the satisfaction of the training and recognizing care. So the act of recruiting and harboring doesn't have to be transport. Since most trafficking in the U.S. begins in the family, you don't have to move from place to place, although transnational, country to country trafficking does occur. The trafficking in the family is compelled labor or commercial sex, and there is an element of fraud, coercion, sometimes so toxic that the individual never fully relaxes, always has the post-traumatic hypervigilance. So let's look at the trafficking again. Understanding human trafficking, severe forms of trafficking in persons. And in this case, with the labor trafficking, involuntary servitude, they never get out of debt. I refer back to Tennessee Ernie Ford, who says, I owe my soul to the company store. And this is what we're talking about, is the coercion, involuntary servitude, debt bondage. And again, physical transportation is not necessary. So I love this definition. Human trafficking is the business of stealing freedom for profit. Traffickers trick, defraud, physically force. Victims are lied to, assaulted, threatened, manipulated, and it is a multi-billion-dollar industry that claims the freedoms of 25 million people around the world. So, we really don't know how many people are being trafficked. In 2014, they estimated 20 million, where 3/4 were women. In 2016, in the U.S. alone, as many as 60,000. 2019, as our awareness grows, it's estimated to be millions. You have to understand that the person is really reluctant to report to police for a variety of reasons. In the past, women were prosecuted for the prostitution that they were forced into, and even if they were children. And of course, healthcare provider identification is the last barrier. We are the slow ones. We're the ones who failed to identify. I had a paper published in the Academy of Nursing journal, Outlook. It's a policy brief on the nursing response to human trafficking. I suggest that you Google it and read what the recommendations were for nurses. Take a breath now, because what is your role in identifying a trafficked person? Can you recognize someone at risk? How do you do that? So I'm going to talk a little bit about trafficking methods. The push factors, and there are pull factors, but the push factors are elements to establish the crime of human trafficking under Palermo. It's the trafficker's action, the means of force, the means of fraud or coercion, and the purpose, which is profit. So these elements have to be together. When you're seeing a victim of human trafficking, there are two ways to approach it. One is it's about the patient, not me, as a provider. And it's always got to be trauma-informed. When you use trauma-informed approaches, victims, depending on their age and stage of development, will interpret the information differently. I think it's important to look at what they've experienced in order to understand who they are and where they are. What was the act? How did they get recruited? Were they transferred? Were they harbored? Were they in a truck for days without food and water? Were they brought here with a ploy and then something else happened? The means, was it fraud, deception? Is there abuse of power? Is there a threat of force? Maybe threat of force against a family in another country. So why the exploitation, prostitution, even organ removal, forced pregnancies that are undocumented for baby parts, forced soldiering, exploitation. So how can we help if we don't see it? So what do patients say about us? I can tell you that they seek care from us, and it's a critical component. Their study interviewed sex trafficked persons, and what they found is that most visited a healthcare setting. Barriers to disclosing were obvious, and there were reasons for seeking care. 21 persons were willing to talk to them, and what they found is shame, lack of inquiry were the two reasons why they did not tell what was happening. Now, Richie was really good about this, and it gave us an insight about the role of shame, and has really spun off an entire body of literature related to shame. We need to fill that training gap about what shame is. Much too long for this presentation, but we also need to teach trauma-informed and patient-centered approaches, and there's an entire body of knowledge developing under trauma-informed care. So who are the vulnerable? Well, history of violence and neglect, child abuse, seeking better life, migrant, no social support, male parental figures, indigenous homeless, runaways, mental health. Seems like our foster care system is a huge producer of potential victims. So what are the push factors? Ignorance, you don't know about it. It's a societal problem. Poverty, runaways, war displacement. How do we fix these larger societal problems to minimize the impact of human trafficking? So here's an example of a girl who, I got this from Trafficking in Persons report. He was my boyfriend. He made me sell sex on the internet. So the pull factors, demands for workers in the sex industry. They target children and homeless, LGBTQI. They also have people who purchase children. This is the largest pull factor. And exposure and prosecution of those who purchase is the next part of the iceberg to chop off. You see, trafficking meets a triple bottom line. In this case, Michael was trafficked because he was looking for a better job in the United States. He was told he'd be part of an escort service, and instead they forced him into prostitution, and he stays with other men 18 to 20 hours a day without pay, and if he leaves, they threaten to kill him. So how do they break people? Well, they tattoo, and that still seems to be the #1 way to do it. And the lure is the boyfriend is first customer. And he actually does give a reward, usually financial, usually something wanted. And then the next one is not so easy. They exploit their feelings. They threaten them with turning them over to law enforcement. And because they're children, they don't know that that's not going to be a problem, particularly if they are immigrant children with deportation. And then there's a thing called a toxic trauma bond that actually resets the thermostat of the vagal nerve. This is where the fear is constant, 24 hours a day, and it is unpredictable. So when a couple hits a hard time, the male partner suggested the wife consider prostitution. He forced her to continue after the time was up. He controlled everything. Sounds a whole lot like domestic violence, doesn't it, with trafficking. I gave you a film here with a YouTube link to listen to Barbara Amaya, who talks about the push-pull factors in her own life. She's an amazing woman who escaped and now is explaining to all of us what it's like to be in the life. So here's some language you need to know. The bottom bitch, bottom or bottom bitch, these are the people who actually supervise and reach out to others. Think about the Jeffrey Epstein case and the woman who recruited. She's the bottom bitch. They operate as the right hand. They inflict punishments when they're not acting right, and that is the victims. And familiarity without understanding breeds a vulnerability. So I will say to you, if you're thinking about, well, how did these children get in this life? I will tell you that your child is vulnerable too. And the only solution has been there in my research related to adolescence and upcoming research publication. The only thing to avoid here, avoid this life, is supervision. You have to supervise your teens. And you have to supervise them and not only know where they are, but know who their friends are and you have to talk to them. And you have to tell them about the ploys to get them into the life. So branding is another aspect. The pimp takes ownership of the victim, and there are all kinds of things. So daddy is the term the pimp will tell them to call him. Family folks is another one. Language is very specific to the culture of that community. So what means one thing in one family may mean something else elsewhere. That experience of coercive toxic trauma bonding is akin to brainwashing, and part of the therapy that is ongoing with those who eloped from the life is repatterning brain thinking. So have you heard about carving and branding? Well, when you have a handprint on your body, it pretty much says you belong to that handprint. Here's some other ones: tattoos, recognition, barcodes, stamps with names, that kind of thing. Almost all sex traffickers in America now brand crowns, bags of money, initials. Some of the women are branded with unique barcodes. And in order to understand what's happening, you have to understand that just like in any other work life, there's a quota, how much money they have to make before she can come home. And for many, it's significant. In working in the drug court, I've had patients that have had as many as 1,000 sexual partners in a week's time. In an area of town known for prostitution and activity, it's called a track. Usually there's pornography and strip clubs, things like that. They also trade each other up and down when the child who is no longer a virgin and no longer valuable is traded up to another one, wifey and sisters-in-laws under the control. If they're no longer valuable because they're pregnant, they may be traded down. The whole point is a continual control method to break that individual psychologically and physically. It's akin to abuse and torture. They make them an example for the others not to act up. They withhold money, identity. They threaten family and children. If they're pregnant, they exploit that, and they use a lot of guilt. This is in a publication that one of my students and I and another faculty did. It conceptually analyzed trauma coercive bonding so that we can begin another understanding of those who are more seriously impacted by the type of trafficking. So what do you see when you look at your fellow man? Well, some people see profit. There are more people enslaved today than there was in the entire 300-year of the Atlantic slave trade. So here's another human trafficking BBC film with the YouTube. I leave that for you to watch. And take a breath, because this is tough stuff. Get that deep breath in, cause that diaphragm to go down, relieve that stress. It's hard to hear about human trafficking. So who are the pimps? 19 to 45 years old, average education is 9 years, 50% complete high school, most have drug and alcohol use, most have criminal records, and they make between $150,000 and $200,000 a year per child trafficked. They exploit an average of 4 to 6 females. Do the math. There are 3 kinds of pimps. Economic, business pimps, looking at it, they create the debt bonds. The boyfriends groom them to exchange sex. They lead to a toxic and often necrotic trauma bond, much like domestic violence. And then there's the gorilla pimp. They abduct and force, and they create fear, and they also deny any kind of social support. This is the most serious kind of trafficking, and when they emerge from that, they need significant interventions to remove and reverse brainwashing. Triple bottom line of trafficking, that basically says that billion-dollar business, there's a profit, a planet, and a people. It meets the needs of the present without compromising the future. In fact, they say that this is more profitable than the drug trade and gets no jail time. So why would they be selling drugs when they could sell people and make more money? Through supply chains and labor subcontractor, businesses face a number of penalties that are in the legislation in the United States. Lots of legal troubles and lost business. Again, though, it's still more profitable than drugs. So what is the profit? Let's look at that again. Low risk is the 12 to 25-year-old, typical age female who will protect her pimp. The high reward, 900 profit a day, 1 female, 5,400 a week, 280,000 annual, 3,200,000 for 10 females trafficked. There's also another risk reward, and that is that these girls are taught to maybe labor trafficked into the service business of restaurants, things like that, and they steal credit cards. And so there's a huge credit card fraud component to that. Organized crime involves money laundering, sophisticated, highly profitable criminal enterprises, and there also are cross-border financial flows. We see that with the cartel in Mexico, who collect from money on one side and then traffic the child multiple times into the United States. There's heavy reliance on international cooperation, and what they're doing is when they are successful, they are confiscating the criminal proceeds, and it goes into victim services and interdiction. So where are the victims? We've talked about this. When you are riding in your neighborhood, they're at truck stops, commercial front brothels, hotels, motels, even on the street, private residences, internet webcam, pornography, strip clubs, escort services. Truck stops are particularly vulnerable to trafficked persons. So why do victims leave? They felt a willingness. This is Vergiver et al. They felt a willingness to work toward their future, a strong need to turn over a new life. Seemingly against all odds, while they're faced with several external regulators, these external regulators are actually, we're one of those groups. We actually can foster autonomy, promote decisions related to movement to life with a job, family and friends, or we can diminish this particular thinking. They have hope. They have hope for having a better life. They don't have coping mechanisms. We can help them cope with the problems in the past, not by telling them it's not your fault, but rather explaining that this is a journey and an exploration. It's unique to them and their experiences, and it will build on their strengths, not on ours. It's a future-oriented, and we've heard this term, strength-based approach to service provision and responsiveness. Again, this requires a coordinated community response that may be going on in every community that is served by this health system. So I want to introduce you to the tip 57 I talked about. The first step is creating a trauma-informed environment in organizations. Well, what does that mean? I recommend that you Google Clinical Pearls Spec Trauma-Informed Care and watch a 35-minute YouTube explaining what trauma-informed care means to healthcare providers. It is a patient-centered approach using a simple understanding that I must enlist the patient's cooperation in any plan of care. And if they decline, it could be that what they are declining is not what I'm recommending, but they have a life out there that may put them or their families in jeopardy. So let's talk more about that. Trauma-informed care principles are promoted by the CDC and the websites on this slide. Safety, trustworthiness, peer support, collaboration, mutuality, empowerment, choice, cultural, historical, and gender issues. Now, what does that mean? The body of evidence is increasing, and trauma-informed care is not accomplished through a particular technique or checklist. It requires a constant attention to the organizational approaches to human beings. In nursing, we value all human beings in all their forms. That's in our codes of ethics. The question is do your organizational values line with trauma-informed approaches and community stakeholders? So, how are you going to identify? Don't look at the typical victim, okay? You look both at adults and children, because the child who appears to be pseudo-mature, wearing too much makeup, a little bit risky clothes, they may say they're 18, but maybe they're 15. If there is an admission of prostitution, it's probably a trafficking situation. And I'm going to tell you, victims do not trust us. And they have a right not to trust us. We typically report child abuse. We're mandated to. But unless they are ready to elope, if they're ready to elope from the life, then they want you to report. Trust is not automatic and might take 2 or 3 visits. And most trafficked persons, particularly for STI treatment, will come in 3 times a year. If you think about their lying about the situation, think of it in terms of a mechanism learned to protect their personhood. And don't think badly of them. It is a response to survival. And they don't understand the word trafficking. So if you understand that, they're operating out of fear and they're making decisions that are based on their environment. I once had a person tell me, you can't do a home visit on my grandmother on that day. I found out later that they were prostituting out of the house and doing drugs. She was protecting me. So you must think that there's something they're not telling you about themselves that really is a protective mechanism for you. The language they use is different. I've given you some of the words today. An old adage from my mother, listen twice as long as you talk, and they may actually give you even more information. So here's some more stats. African American and Latino youth are overrepresented in child sex trafficking. Juvenile prostitution, the studies consistently report 50 to 90% have been involved in the child welfare system. This history is important for the healthcare provider because it segues into other life experience histories that are really important as you're gathering the information. Refugees and migrants indicate they've been trafficked and exploited minimally for their labor. Homeless youth that identify as LGBTQ, 40% of them have been trafficked, even though they only represent about 5 to 7% of the population. So when you think about runaways, think about 1 in 7 of them are reported missing and exploited when we finally find them in a trafficking situation. So 88% had a visit with a medical provider. That's 3 out of 4. They presented with STIs, exacerbations of untreated chronic disease. They're suicidal. They've got a drug ingestion. They want contraception. In many cases, their pimp will come wanting an abortion, or their complications after pregnancy or back alley abortion that they're seeking help for. Because remember, that individual child is valuable, so they want to get them treated so they can put them back on the street. They're not going to be happy if you have to hospitalize. Okay, so they're under our noses. Again, they report seeking medical care. Look at what for, and this is Curtis's study. STI testing, HIV, treatment for acute chronic, broken noses, bruises, head injuries, dental injuries, hepatitis. They're under our noses. So how do you inquire? Okay, so we have VERA guidelines. This is an extensive validated study that has the lengthy evaluation tool that brings human traffic victims out of the shadows. And I've got the URL for you. There is a shortened form, okay, but you have to set it up in a pre-interview. You set up that safe space. That's trauma-informed care. You address any fears they have. You provide breaks and things like that. You fulfill their basic needs. You never interview with the trafficker there. Develop a rapport with them. Be honest. Describe to them what their rights are. Tell them about the interview process and the roles of all the people that are around them. If the English is second language, provide an interpreter that is not one of their inner persons. Assure confidentiality and be culturally sensitive for their preferences. So start with general conversations. You're establishing a trustworthiness. Be patient and caring and sensitive to their fears. Explain their fears and facts. If they're fearful, say, it looks like you have a little bit of fear here. Tell me about what's scaring you. If they look around and they're thinking, well, you don't have to tell me today if you can't put it into words, but I notice that this is making you uncomfortable, because they may not have ever defined what fear is for them. Convey messages of support. Tell them that you're experienced working with patients who have found themselves on a life journey of trauma. Allow them time to recount their important experiences. Remember that memory is built through association. The memory that's built through association may get you the things that were significant, but it's not until they journal or are able to associate with others that you begin to get the details. Because think about yourself. If you've been to football games your whole life, can you tell me what happened in a particular football game? Likely not. But you could probably tell me the football game that had a Hail Mary pass and your family member was involved. Well, think about the human trafficked person like that. And that is that these experiences are so traumatic and so robust that likely the only things that they're going to remember are the things that were the most frightening. I asked a young woman who experienced infibulation before she was trafficked, what did she remember? And what she remembered was when the woman that she trusted took her into the surgeon. Now that's significant. So when you look at memory, think about it takes time for persons to recount what happened to them. And in your 10-minute ER visit, that is not going to happen unless you have a team approach to persons who are vulnerable. Remember, if they are trying to elope, they risk everything, their lives and their families' lives. So it's important to gather information for treatment. If you have an attorney-client medical legal partnership in your ER, that's certainly something you want to involve the attorney with, particularly the attorney that understands what the legal ramifications are if they're not American citizens. How to drive and share this information under HIPAA and minimize staff contact with this person. Keep a poker face. They will tell you things that you cannot even imagine, and they think are normal because it's happened so many times to them, but it's not normal. So express sorrow but not judgment, screen them for mental health outcomes, and responding normally to abnormal events is not a mental health disease. Anxiety, when you're afraid of a person, is not a diagnosis. It is a symptom of fear. Consider the impact of triggering unpleasant neurobiological responses and the victim's experiences, which many times are polyvictimizations. And for me, many times they are crimes. There is a tip to drive this home. I want these repetitive experiences. Holidays come to mind. You may have a general memory and they may remember it was cold or that somebody started to school or whatever. Using this tool correctly helps people feel supported and safe. Remember that multiple incidences, they're not lying if they go from event to event and it happened on different days. Rather, these incidences were the significant ones. So when they were the first rape or the first beating, that may come out and then another beating get mixed up with that first beating because beatings are beatings. General memories. Specificity is not spatial. What it is sensory. Ask them what they saw, heard, felt, tasted, smelled. And it's likely you're going to get a more accurate history. So tracking the individual. This is the TVIT. Integrate these questions into your history. These tools that I've provided for you will help the patient explain their role, the choice of participation, but be sensitive to their anxiety or responsive to different cues that may be coming from you. An example of that, when I was a young practitioner or family practitioner, a child came in and she says, "I don't want to see you." And I looked at the officer and she said, "You look like the bottom bitch." So what I did is I took off my glasses and pulled my hair back and said, "I am not this woman." So there are cues that can occur that are sometimes generalizable that you may not understand, but be sensitive to them. So the questions include a screening background, personal background, things that are general that we do all the time. Living and working conditions, and then it gets a little dicey because they don't know what you're after there. And then for additional comments, there may be some spontaneous disclosures. Always do a post-interview assessment. And what that means is How did I do? Do you feel supported? I'm very interested in your well-being. Is there anything else I can do? So the medical forensic evaluation is what forensic nurses do, and if you're fortunate to have forensic nurses in your system, they'll look at assisting in the setup of trauma-informed care, motivational interviewing, crisis response, and knowledge of long-term treatment for trafficking experiences that are located in the community of supporters and stakeholders. There actually is opportunities for intervention. In particular, you will see these patients come back. They will be medically needy, and sometimes the red flags are listed here on this slide, and this is from Curtis et al.'s work. And so a lot of times when they're in the process of deciding to elope and leave the life, these are the things that will come in, and as long as you continue to reach out in a therapeutic way, you're going to find that they're going to be more able to. I also think there is a developmental approach, and the expectation is by 25 to 30, most people have a mature brain and can begin to put two and two together and make choices about their lives. So he showed me so much interest. This is a disclosure. I was 14, it hurt, I didn't like it, I felt dirty. We saw that recently with a Jeffrey Epstein victim disclosure. This is not an uncommon disclosure when rape is the first sexual encounter. So up to a third of those rescued began with Romeos. There's a study on Las Vegas trafficking that I would refer you to. There's an AMA Journal article of ethics to discuss the public health approach to mandatory reporting of human trafficking. And I will tell you that the public health approach is the best because it actually allows for a system-wide approach all the way down to an individual patient encounter. Food for thought here. The AMA article has articulated principles for physicians' ethical decision making, and it goes along with what I've been talking about and actually parallels nursing. Respect for autonomy, non-maleficence, let's do no harm here, beneficence, let's do good, and justice. Justice means different things for different people. But again, this is the URL to take you to that report. And so what do you do in the first victim encounter? I'm going to tell you if your hospitals are a safe place, kids know about this and they will come in. I will also tell you the best investigations occur when everybody's involved, and the local hospitals are part of the multidisciplinary team responding to this. Now, you do have to report if there is an injury from a gun, stabbed, burned, but not human trafficking. Create safety as much as possible. How that victim is questioned sets the stage for disclosure, and know that you're part of that process. There are also, for non-U.S. citizens, there are federal laws that protect them through T visas, and they're considered a refugee. There will be a certification letter. They will have to go through court for that, but that's where the community organizations come in. The criteria for the certification letter does not apply to children under 18. So why is that important? Because if you've identified a person in your emergency department that's under 18, they are treated as children. They are not emancipated sexually anymore. And why is that? And I'll talk about that in a minute. So there are United Nations. Prosecution will occur under the Palermo Protocol and under federal guidelines. The whole point is to identify, rescue, restore, and protect from retaliation. And that's the U.S. Department of State. The Blue Campaign is another one out of Homeland Security, and you can Google that and find out what the details are. The HEAL trafficking Again, a professional healthcare organization. And please, if you are interested, sign up for their blogs. There is a Joint Commission advisory. I have the URL here so that you can make sure you're in compliance. It's safety actions for healthcare professionals to consider while keeping victims safe. Now, why is that important? Because there is a life-threatening danger to them and to you. If you don't recognize it, then you could become the next shooting victim. So, if it's suspected, you want to remain non-judgmental, use the plain language. I could read this to you, but you can find this on the Joint Commission website. Make sure that the patient is protected. Build that trusting rapport, and if they elect to leave, let them know they are welcome to come back. Here is the policy brief on nursing response to human trafficking. I will tell you the outcome from this publication in August of 18 resulted in February 19. February 19, changes in Title 10 rules and regulations that mandate reporting of children in Title 10 clinics if they are abused in domestic violence situation, dating violence situations, or are human trafficked victims. So to protect the women and children experienced in the child abuse, child molestation, incest, it requires annual training. Many states are now passing laws requiring it of healthcare providers. And these Title 10 clinics now are required, mandated annually to have this kind of training. So in summary, the entrance and exit into and out of trafficking is best understood in the context of racial, gender, and economic oppression. It results in an unreliable access to health care and child care, housing, lack of resources and options and opportunities. Our policy approaches must acknowledge these realities and really begin to focus on that triple bottom line and creating interdictions that dry up the economic benefit. Prostitution and trafficking don't occur in a vacuum. So when an organization such as St. Vincent's takes notice, it begins a series of questions to how we as an organization can best respond to human trafficking and other vulnerabilities that patients bring to our doors seeking help. Remember that it must be comprehensive, culturally and contextually relevant, and multisystemic. I want to thank you for this time, and I also will let you know there's a series of resources that will be printed up for you for use as you grapple with these very difficult healthcare provider questions. Thank you again.